Hello everyone. The topic of today's discussion is polymorphous low-grade adenocarcinoma. However, according to 2017 update, it is now being considered as polymorphous adenocarcinoma. So we'll be covering the topic under the following headings, starting with the introduction, followed by the histogenesis, clinical features, followed by the histopathology, treatment, and the summary. Starting with the introduction, when we talk about salivary gland tumor, it is the second most common salivary gland malignancy. It is exclusively found in minor salivary glands. So it is the most common salivary gland tumor of minor salivary glands. But when we talk about the most common salivary gland neoplasm, instead of benign or malignant, the answer is pleomorphic adenoma. However, if the question is most common malignant salivary gland tumor, the answer to this question is mucoepidermoid carcinoma. So the first most common salivary gland neoplasm is pleomorphic adenoma. If it is malignant, it is mucoepidermoid carcinoma. And the second most common salivary gland tumor in minor salivary gland, it is polymorphous low-grade adenocarcinoma. Now, when we talk about the histogenesis, salivary gland is formed by a ductoacinar component in which we have the luminal cell population and the abluminal cell population. In the luminal cells, we have acinar cells and we have the duct lining cells. Whereas in the abluminal cells, we have myoepithelial cells and the basal cell. So when we talk about the histogenesis of polymorphous low-grade adenocarcinoma or PLGA, it can be derived either with the combination of luminal plus abluminal cell population. It can be only from luminal cell population, or it can be purely from the myoepithelial or the basal component, that is the abluminal component. So it can arise either in combination from luminal and abluminal population or either of. Now, starting with the introduction of PLGA, it is a malignant epithelial tumor and it is characterized by bland cell population with uniform nuclear features, but it shows diversity in the histology and the architecture. Now, when we talk about its growth, it is infiltrative in nature and it also shows perineural invasion. This term, polymorphous low-grade adenocarcinoma, was first used by Evans and Batsakis in 1984. Till that time, the tumor PLGA includes all the tumors such as terminal duct carcinoma, lobular carcinoma, papillary carcinoma, and trabecular carcinoma. Now, it is the second most malignancy in the minor salivary gland. When we talk about the age predilection, the most common age is 7th decade. When we talk about the gender predilection, it is more commonly found in females. The ratio is 2:1. Usually, it is painless. It is a submucosal mass. And in the morphology, it shows diverse features. When we talk about its presentation in minor gland, when we compare PLGA with adenoid cystic carcinoma, it is twice more common than the adenoid cystic carcinoma. Coming on to the site, the most common site for PLGA is soft palate or hard palate, about 60%, followed by buccal mucosa, followed by upper lip. It presents as a non-tender swelling, which involves the hard palate and the soft palate. Occasionally, there can be some discomfort, bleeding, or telangiectasia. Sometimes ulceration can also be appreciated, but in few cases. Now, when we talk about the histology, this PLGA has derived its names because of its polymorphous nature. That means this tumor shows infiltrative growth with diverse histomorphology and with uniform cytological feature. Although it is a malignant tumor, but it is a low-grade malignancy, so it is well circumscribed, but it is unencapsulated and it tries to infiltrate into the adjacent structures. When we see the tumor cell component, they are usually cuboidal to columnar, but they are isomorphic. That means they are similar in size and shape to each other, and the nuclei which are present inside are uniform. They are ovoid to spindle shape. Now, when we see the characteristic histopathology of PLGA, two types of cell population can be appreciated. One is isomorphic cells, which are cuboidal to columnar. They have indistinct borders because the cytoplasm is faint and the nuclei are uniform with no sign of any pleomorphism. Also, there is a characteristic feature of PLGA, that is Indian file pattern. What is this pattern? As the soldiers are arranged in a linear fashion, the same way the tumor cells are arranged, and this pattern is known as Indian file arrangement or Indian file pattern. Now, when we talk about PLGA, since it is in its name itself explains that it is polymorphous, that means it shows histological diversity. So the tumor cell can arrange themselves in the form of solid pattern, tubular pattern, fascicular pattern, cribriform pattern, or papillary pattern. So starting with the solid pattern first, in which the tumor cells are arranged in the form of sheets, and these sheets unite to form solid pattern. in which the tumor cells are cuboidal to columnar. The cytoplasm is faint, the uniform nuclei are present without any marked pleomorphism, and the peripheral layer of the cells show slight palisading. The second pattern is the tubular pattern, in which the tumor cells are arranged in the form of small tubules, and these tubular structures are lined by single layer of cuboidal cells. Now, the third pattern in the histopathology can be fascicular pattern, in which the tumor cells fusiform together and they are arranged in short to long fascicles, giving rise to the fascicular pattern of the tumor. The fourth pattern is the cribriform pattern, in which multiple pseudocystic spaces can be appreciated. These pseudocystic spaces are filled with amphiphilic mucoid content, and these spaces are lined by pale cell layer of cuboidal cell, and it is a single cell layer, giving a cribriform appearance. Because of this cribriform appearance, it gives histological resemblance to adenoid cystic carcinoma. The last pattern is the papillary pattern, in which the tumor cells get papillary configurations of cuboidal to columnar cells. And the characteristic finding in cases of PLGA is the Indian file arrangement, the perineural invasion, in which concentric targetoid appearance can be appreciated. And because of this perineural invasion, it can be mistaken to adenoid cystic carcinoma. Also, in the background, we can appreciate abundant mucin, and this abundant mucoid stroma will give a characteristic blue-gray hue to the cases of PLGA. Now, when we talk about the immunohistochemical approach to diagnose PLGA, it can take its origin either from the luminal population or from the abluminal population. When we talk about its benign and malignant nature, so the Chi67 labeling index is low, it is below 10%, so it is a low-grade malignancy. And to rule out it from pleomorphic adenoma, glial fibrillary acidic protein can be done, which came out to be negative for PLGA and positive for pleomorphic adenoma. Also, S100 can be done, which came out to be strongly positive for PLGA, to rule out it from other pathologies. Now, there are two major entities which need to be differentiated from PLGA. One is pleomorphic adenoma, in which the borders are well circumscribed, however pseudopods or pseudoinfiltrations can be there, whereas in cases of PLGA there is clear-cut neural invasion. When we see the morphology, the cellular composition of pleomorphic adenoma, it is usually biphasic, ductal and myoepithelial both components are there. However, in cases of PLGA, it is monophasic. Rarely it shows myoepithelial differentiation. When we see the cytology of pleomorphic adenoma, we can appreciate the ductal cells and the angulated myoepithelial cells, whereas in cases of PLGA, there are uniform monomorphic cells with uniform nuclei. When we see the background, the pleomorphic adenoma show characteristic chondromyxoid background along with the melting phenomena of the myoepithelial cells, whereas in cases of PLGA, it is hyalinized and mucinous. To rule out pleomorphic adenoma from PLGA, we can do immunohistochemical markers such as GFAP, PLAG1, which is characteristic for pleomorphic adenoma, and Chi67 labeling index, which is less than 5% for pleomorphic adenoma, whereas in cases of PLGA, it is more than, it is between 5 to 10%. When we talk about the molecular alteration, it is PLAG1 in cases of pleomorphic adenoma and PKRD1 mutation, which is a hotspot mutation, and it is highly specific for PLGA. Also, we need to differentiate it from adenoid cystic carcinoma, which is usually biphasic, whereas PLGA is monophasic. In adenoid cystic carcinoma, we appreciate basalloid cells with angulated nuclei, whereas in PLGA, there is monomorphic cell population. The adenoid cystic carcinoma will give cribriform pattern with basophilic mucin, whereas in cases of PLGA, polymorphism can be appreciated with focal areas of cribriform areas. That is just a pattern of PLGA. When we need to rule out the immunohistochemical panel for adenoid cystic carcinoma and PLGA, S100 came out to be weak, whereas it came out to be strongly positive in PLGA, and P63 came out to be positive in adenoid cystic carcinoma, which is weak in PLGA. When we talk about the molecular or the genetic alterations, MIB alteration is seen in adenoid cystic carcinoma, whereas the hotspot mutation, which is specific for PLGA, that is PKRD1, is not seen in cases of adenoid cystic carcinoma. Now, when we talk about the treatment, the best treatment is the wide surgical excision. Although this tumor can recur, however, distant metastases have not been reported. Therefore, the prognosis is good. Perineal invasion is found in PLGA, but it will not affect the prognosis. Therefore, neck dissection is not required because distant metastasis is rare. So to summarize, when we talk about PLGA, it is a malignant neoplasm of salivary gland origin. It is the second most common malignant salivary gland tumor after mucoepidermoid carcinoma. It is exclusively seen in minor salivary glands. Few cases can be reported in other glands also. The most common site are palate, followed by buccal mucosa and upper lip. When we talk about the gender predilection, more commonly found in females. The age predilection is 7th decade. The hotspot mutation which is seen in PLGA is PKRD1. Clinically, it presents as a firm, non-tender swelling, which occasionally can produce discomfort, bleeding, telangiectasia, or ulceration. When we see the histopathology, the cell population is isomorphic with indistinct borders and uniform nuclei, and the characteristic finding is the Indian file arrangement. There are varied histopathological patterns such as solid pattern, tubular pattern, fascicular pattern, cribriform pattern, and the papillary pattern. The characteristic finding of PLGA is perineal invasion, because of which it can be mistaken with adenocarcinoma carcinoma, and the treatment which is required is the conservative white surgical excision. Thank you.